So this next session we're going to do for the next 50 minutes or so will be talking about antibiotic stewardship across all healthcare spectrums. And I think you've already heard throughout the contents and the presentations of today, so this terminology of antibiotic stewardship sort of sprinkled throughout. And we're going to try to give you a little bit more, hopefully this panel session will give you a little bit more better understanding of what antibiotic stewardship really means, what types of activities do they entail, and why do we need stewardship activities. So my name is David Hyun. I'm a senior officer with the Pew Charitable Trust with the Antibiotic Resistance Project, and I lead the project's work around antibiotic stewardship in human healthcare settings. We also have a stream of work that focuses on animal agriculture antibiotic use, and another set of work that focuses on drug innovation. Just before I introduce our panel speakers, we will just to sort of set the table about what antibiotic stewardship is. So antibiotic stewardship is a set of activities, policies, interventions, whatever you want to call it, that are all designed really to make sure that the best therapeutic decision is made when it comes to antibiotic prescribing for the patient. So we tend to focus a lot about these discussions around how much we can reduce unnecessary antibiotic use or inappropriate antibiotic use, but equally important is that when antibiotics are truly indicated, such as sepsis, as you heard a great presentation from Tom Heyman earlier today, is that when antibiotics are truly needed, we also want to make sure that the correct type of antibiotic is used, the correct dose is used, and the correct durations are selected so that we give the best chance for the patient to have the best outcomes. And in the process, we're also trying to minimize the risks associated with antibiotic use, such as C. difficile infections, as well as antibiotic resistance. And so we're going to talk about antibiotic stewardship because we know from data that's been published so far that there's a lot of room for improvement of reducing unnecessary inappropriate antibiotic use or optimizing therapy. So with that, I'm going to ask our speakers to introduce themselves. They're all physicians, and they all represent actually a fairly unique set of practice or realm, so to speak, of antibiotic stewardship. So as they introduce themselves, I'd like to ask them to sort of, in addition to providing some context, a brief background of the type of work you're doing in antibiotic stewardship, but also why antibiotic stewardship is important to you, reflecting your personal and your professional experiences.
So I get to go first here, I assume. So I'm Laurie Hicks. I am the director of the Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion at CDC. And interestingly, I'm also married to a gastroenterologist. So for better or for worse, my husband and I often have conversations about C. difficile and antibiotic use over dinner. But I really care about this problem for a number of reasons. And at CDC, we believe that improving antibiotic use is fundamentally about improving patient safety, as David was mentioning, and really improving the quality of patient care. Whether we're talking about preventing C. difficile infections, reducing the burden of antibiotic resistance, or treating sepsis in the best way possible. And it's really been great to be here today to meet many of the patient advocates who are working on this issue, because it's really those personal stories that make the most difference in terms of getting the word out about why we should be concerned about these problems. From the CDC perspective, we're very engaged in learning about how antibiotics are being used, identifying the best targets and the important targets for improving antibiotic use. For example, we've done work actually with the Pew Charitable Trust to look at how many antibiotics are being prescribed unnecessarily. And just in the outpatient setting, in doctor's offices and emergency departments, we know that 30% of all antibiotics being prescribed in those settings are completely unnecessary. So there is a huge opportunity to improve how we're using antibiotics in that setting. We also know that there is a lot of opportunity to improve antibiotic selection. And you'll hear more from the rest of the panel about other opportunities to improve. And I would also say that, especially because this is an event promoted and sponsored by the Peggy Lillis Foundation. I want to mention that 10% of all antibiotics prescribed in outpatient settings are prescribed by dentists. And we're just learning that there are a lot of opportunities there potentially to improve how antibiotics are being used.
Thank you. I'm very happy to be here today and to have met many of you last night and today. My name's Sarah Cosgrove. I'm an infectious disease doctor, and I am the medical director of the Department of Antibiotic Stewardship at Johns Hopkins Hospital. I actually started in the area of antibiotic resistance as a fellow. That was a long time ago now, but and I was doing kind of epidemiology and outcomes work around antibiotic resistance, and decided at some point that I am not going to do that for the rest of my life because there were a lot of problems that I found, and I'm much more of a fixer than just a database person. So I think I was very fortunate to fall into the world of antibiotic stewardship starting in around 2002, which is a long time ago also. And it has just been remarkable to see what has happened since I fell into that to 2017. And I think to see more and more hospitals across the country have stewardship programs, and to have stewardship expanding now out into long-term care and even into the ambulatory world is fantastic. And I think that is why I made the comment earlier that I actually have some fear that we're going to go backwards. And we've come so far in the past, really just 5 years, that the thought of going backwards is very painful to me. But I know we will persevere. So, and then I will just say, on another note, a non-academic, non-infectious disease note, but as that of a daughter, my mother, after being treated for community-acquired pneumonia, developed a C. difficile infection. And I'm an infectious disease doctor, and I do antibiotic stewardship. And when I think back at what happened in her care, one of the things that is obvious to me, even as me being, in the profession and in even having the particular expertise for the condition she was being treated for, was how difficult it was to intervene in the pathway of events that led to her getting C. diff. And just one of those things was she had been labeled as having a penicillin allergy. And I said, you don't have a penicillin allergy. Please tell them you don't have a penicillin allergy. And that it took forever for that to get removed from her chart, but not before she got fluoroquinolones that led probably to the C. diff. And so, I feel like I should be able to do a better job or have more access to making sure that her care was more seamless, and I didn't. And so I just respect everyone here who is trying to do this, and I think we really collectively need to think about, as patient advocates, all of us having either personal or family experiences, having communication problems and seeing these things happen before our eyes. What can we do to improve that? And what can we do to empower patients to be able to speak up when it's so hard, right? Even me as a doctor in that field, having trouble altering what was happening. Thanks for listening.
My name is Bruce Hirsch. I'm an infectious disease doctor. I chair the Pharmacy and Therapeutics Committee at my hospital and involved in medication safety. And Sarah, your comment about how difficult it is to be a patient, I've heard over and over again. The doctors and nurses that have worked in the hospital for decades, when we're patients, there's something that is shocking about that experience. And I think that fact is an important, is important information about the nature of our healthcare system. We need to empower ourselves. We are doctors. We are all patients. We are all patients' families. And being open to the actual experience of other individuals, I think is important not only personally, but also biologically. And for me, it is a biologic miracle that fecal transplantation has as dramatic an impact as possible. I'm an infectious disease doc. I kill bacteria for a living. And a couple of years ago, inspired by Dr. Brandt, inspired by my patient who was tired of months of diarrhea, took Imodium, ended up with toxic megacolon, and died in our hospital, inspired by those experiences, starting to do fecal transplantation, it has changed my understanding of what antibiotic stewardship is. And I think that the data that indicates that we live in community with our gut microbiome, that our gut microbiome trains and tones our immune system, that antibiotics have adverse effects that we have not appreciated. Decades ago when I started, all of our doctors were giving antibiotics just in case there was a problem. And antibiotic stewardship, I think, represents a real revolution of understanding and advance in clinical care.
Thanks, guys. This is awesome. You guys are fabulous. It's hard to follow all that. So my name's Jason Nuland. I'm a pediatric infectious diseases physician at St. Louis Children's Hospital and affiliated with Washington University in St. Louis. I've been in the world of antimicrobial stewardship with pediatrics since about 2006. My story is I failed in the lab. But this is a passion of mine. And for the past 10 years, I've been involved in developing inpatient kind of making sure we use antibiotics appropriately for the hospitalized children. We started to work in the outpatient setting and looking at communication and behavioral techniques because obviously, as mentioned, talking and this is a behavioral change thing, and this is the communication. And so it's and I think from a C-Diff perspective, it happens in children. It's increasing in children. We know it's primarily in the community that we see it. We don't see as often the toxic megacolons, those that I've met many of you who suffered some of these horrible consequences of C-Diff. So that is good, but it is what I consider one of the major adverse drug events. And when David asks us, well, why? What's the passion that drives you? And it takes me 2 seconds to think what's the passion that drives me in this work. So I have 3 children. My youngest now is 11. And when she was 6 years old, one morning my wife screams my name as I was getting ready for work. And I come and look, and my youngest daughter had a red, swollen eye. Big, fat, red, swollen eye. So as a pediatric infectious disease person, if I show the picture of a slide, and everybody in the room, from a physician, clinician, nurse, anybody goes, oh, that's orbital cellulitis, essentially an infection that's behind your eye, right? And I was like, oh, rat. I was like, oh, rats. I got ready for work. I grabbed her. We went to the emergency department. She got a CT scan. I have a picture with her thumb up after she's gotten her IV in. I didn't worry one bit, right? I had no worry about her really getting, I was worried like, oh gosh, I got to get this taken care of, but I knew she was going to get better because you know why? We got antibiotics. That's not an issue, right? And this is in the era that we're worried about some resistant Streptococcus pneumoniae, one of the common bacteria that causes this infection. And so she got some big old bacteria, big old guns of antibiotics, which I'll talk about later. But she got better, and she did great. And you think back, and we started using antibiotics in 1930s with the sulfa drugs. We haven't even made it 100 years. And we have a paper from Jim O'Neill from the United Kingdom who did some analysis that many of you probably know that suggests that by 2050, we'll have an annual number of deaths due to antimicrobial resistant infections, which, by the way, only include about 3 bacteria we normally talk about. Klebsiella, I think MRSA, and maybe E. coli, and then they have malaria and TB in there. And C-Diff's not even in there, mind you, right? 10 million deaths annually, which will outnumber the number of deaths annually from cancer worldwide. And it would cost $100 trillion, US dollars. That's why. That's why I do this. And that's why I was thrilled, honored that Christian asked me to come to speak and to be a part of this panel and to be with you all, because I think this is the way you keep fighting and you keep pushing. And I'm scared like Sarah is, but that's why we are here. Keep fighting and pushing.
Yeah, thank you, everybody, and thanks, Jason, for sharing your personal story as well. And also, I think you provide a very good segue to the first question I wanted to pose to the four of you. You mentioned you use the term behavioral change when it comes to antibiotic stewardship, and I think one of the very instinctive questions we get asked when we quote studies like 1 in 3 antibiotics are being prescribed unnecessarily, or only half the time the doctors are picking the first-line agents for given conditions. The reporters or the general public's first question is, why is this happening? Why, or sometimes they would just be blunt, why are doctors doing this? And I think as stewardship experts, as well as infectious disease physicians, you have probably all very valuable insight and knowledge and a little bit more broader understanding of the complexities behind the reasons why antibiotics are being unnecessarily prescribed or inappropriately prescribed. So I'd like to open it up to the four of you to see what your thoughts are and share with the audience what we know so far about this issue.
So we've done a lot of work on this issue to try to better understand why is this happening. Well, first of all, for many, many years, antibiotics have been perceived to be harmless drugs. So that's for starters. We have to change that perception. So that's something we really need to work on. But there are a lot of other factors that we've learned over the years are playing a huge role in why antibiotics are being prescribed when they're either not needed, or maybe the wrong drug might be prescribed when there's a better alternative. And the most common reason that providers cite, this is really more specific to the outpatient setting, is that when a patient comes or a parent comes to their office and they may indicate what type of infection they think their child or they have, they're much more likely to get an antibiotic if the doctor or the healthcare provider thinks they want one. And it is, an issue of patient satisfaction in a lot of circumstances. And so what we're really encouraging patients and parents to do is to communicate more openly about what they're actually expecting out of the visit. Not necessarily walking in and saying, you know what, I think my kid has strep throat, and because of that, I think the best option is going to be an antibiotic, because in all likelihood, your provider, not necessarily wanting to do the wrong thing, may end up doing the wrong thing because they think you want that antibiotic. There are other reasons. I'm going to just mention diagnostic uncertainty is a big one. It's a big one in outpatient settings, it's a big one in nursing homes, also in the hospital. A lot of times when patients come in really sick, you just don't know what they have to start with. So fear is another big one, and certainly prescribing antibiotics seems to be the safer alternative to not prescribing, but we're learning that that's not necessarily the case. So we have a lot of work to do to change perceptions around both the safety of antibiotics and the association with adverse events, recognizing that these are still life-saving drugs.
Thanks. So I'll comment on the inpatient setting a little bit because it is different than the outpatient setting, and a lot of the data that Laurie has been involved with providing to us, which has been fantastic, thank you, shows us that we're giving antibiotics to patients who really don't need antibiotics. So if you have a cough after you've had a cold, and antibiotics don't do anything for that, but that's a common reason that antibiotics are still prescribed. In the hospital, you've already made it to the hospital, right? So your risk of having a real infection is much higher. So in the hospital, we certainly have a much lower threshold for antibiotic initiation because we obviously don't want to fail to treat someone with the right antibiotic that they need for whatever infection they have. I still believe that there's stewardship to be done even at that decision point for a couple of reasons. One is that we certainly want to make sure that a patient gets the right antibiotic, and sometimes we may even be undercovering for an infection. But a lot of times we overcover, and it's the fear issue that leads to overcovering. And we haven't really ever had as something that you could do wrong over prescribing. You know, it's if you look at a medical team, if you fail to prescribe, then everyone knows that's terrible. But we've never considered over prescribing in the hospital really something bad. And so that's just kind of the world we live in. And over time, I hope that we can work on that. However, there is lower hanging fruit in the hospital, which I think obviously comes around to paying attention to the results you get from the microbiology lab. And once those come back in a couple of days, or with rapid diagnostics now even sooner, tailoring antibiotic therapy at that point. You'd think that was straightforward, but there's all kinds of behavioral stuff that goes along with that also. Sometimes clinicians are suspicious of new rapid tests, and they say, well, how can I trust those results? And so they want to wait for the old-fashioned micro results to come back, even though, ironically, the newer tests are often more accurate than traditional microbiology tests. And then there's the fear of the bug that maybe didn't grow. And these are, we speak of these things in the stewardship world, but these are real. These happen every day in the hospital. And I don't even mean to make fun of them, because they are real and people worry about them. And then the other area I think we have a lot of room to work on that really is pretty easy, or should be, is about duration of antibiotics that we give. So probably going back to the 1950s, which is when antibiotics became available, and they weren't, we didn't have trouble making them, because before the 1950s we had them, but it was harder to make them, so we had to be a little more thoughtful about duration. But once we could just make tons of them, then I think that's how we ended up on the football score durations, so 7 days or 14 days or 10 days. And we really proceeded like that in medicine for forever. And that's what is still done. So we were talking up here before we started that if you want to confuse a bunch of doctors, recommend a 6-day course of antibiotics. I mean, it will generate more phone calls than you can imagine. But really, we need to get over that, because we should treat people for the shortest course that still makes them get better. And the good news is we are starting to have more and more data that really do support the idea that shorter courses for most infectious diseases are just as good as the longer courses. And now we have to get to the business of getting that message out, because I am positive that we will reduce C-Diff as just one of the good consequences of shortening our antibiotic durations. And so, it's kind of a multi-step thing. You have to get the evidence, then you have to change the behavior. And stewardship programs a little bit have to move away from being the police of antibiotics to basically being the conveners around antibiotics, because where we need to evolve to is to get everyone who touches an antibiotic to be thinking as stewards, because thinking of that antibiotic as a precious resource, thinking about their patient and their patient's risks around antibiotics, and doing that themselves. I want them to take my worry, and they take that worry, and they do the right thing with antibiotics.
And I find a lot is coming from the patients. I find that the patients are becoming stewards of antibiotics more and more frequently. And we were discussing fear. We were discussing fear of malpractice, of patient satisfaction. And I have more and more patients that are really leery of antibiotics. And I think that's a representation of the work of this foundation, of other individuals, to get the word out that antibiotics are powerful therapeutic agents that have another side, that have some adverse consequences. And for that reason, the FDA black box warning on fluoroquinolones, Levaquin, Cipro, is actually a very helpful teaching tool, that these agents that are so commonly used, that are excellent antimicrobial agents, have adverse effects, most recently increased frequency of aortic aneurysms, that are really giving pause to both patients and physicians about prescribing these agents.
Yeah, I would just add what I think another driver of kind of this inappropriate use is just how rapidly healthcare has evolved in the short, modern healthcare is 70 years old. And so in pediatrics, there wasn't a field of neonatology 50 years ago. And now we have infants that are born at 24 weeks gestation that are very small and critically ill, and that's scary. And we can have these children or infants survive and thrive. And I think because we can do these things in some really high-risk situations, it gets hard to say, I have this therapeutic agent. I don't know if they are acting really sick. It's easy to give something. Sepsis, we talk about a lot. We worry about a lot in the hospital setting. And I think those are where it gets really difficult. And so there's a lot of gray that we're dealing with at times and that the clinicians are. And I think the second thing I would say is that we're not great communicators. We just aren't. We're not good in the hospitals as well as we should be. We all have our stereotypes. We all talk about the stereotypes. So, the first stereotype or the first one we always implicate is the surgeons. Just go straight, it's the surgeons. But the reality is we don't work well. We have to get to, like Sarah mentions, that these have to be our champions. They have to be our collaborators, because we have to keep working with them and then have them work with us, and that's how we'll affect the major change.
Are you saying it's not the surgeons?
I'm going to say sometimes it is, sometimes it isn't. How about that?
That's very nicely done, Jason. Yeah. So, Jason, I'm going to throw the next question back at you. I'm going to just mix it up here a little bit so we don't keep going down the line here like a conveyor belt. But you mentioned communication issues, and I think I heard a common theme too from Bruce, Sarah, and Laurie about one of the primary reasons why we're facing this situation is whether it's with patients and their families or other provider and colleague doctors. I think there's a lot of fear to allay. There's a lot of reassurances that need to happen when it comes to stewardship, and communication obviously plays a good part. So my broader question, and you can answer this however you want, but broader question. Yeah, I know. So, but the broader question I have for the four of you is: so, what, in your experience, what element of antibiotic stewardship is the most effective element? And it's a very broad question, but I ask this because, and each of you have antibiotic stewardship expertise in different realms. You have a pediatric, outpatient, inpatient, and I'm very broadly stereotyping all of you, and then the public health. But from your own experiences, what is the most important thing when you're designing your stewardship intervention to influence behavioral changes for prescribers?
Yeah. So, right. So from the inpatient pediatric setting where I am, the most effective thing has been communication collaboration. I ended with that, and honestly, I put on the Kevlar vest when I know they're going to tell me no, I'm going to keep doing that, and I say okay, and then you know what? I come back to them again and say, hey, what do you think about this? I don't think you need to use that antibiotic for the chest tube that's still in, that you're afraid of the infection, and you just keep at it, and then we find those underlying things that we're this far apart on whether they should use it or not. And we start talking about how are we going to bring it together. So I think that's on the inpatient, and I also believe it's in the outpatient. Laurie mentioned the aspect of this perception issue. And if you look at the studies where they've actually surveyed those of the families and the parents, usually these are pediatric studies, they're like, I didn't really want the antibiotic. I just wanted you to tell me that things were okay. Right? And you guys have said this. Everybody I've heard that said like 3 or 4 times just today. And I think we as the clinician side forget that. And so I think those are so I'm big communication collaboration now over the last year and a half or so.
I'm not sure what's most effective in outpatient. My wife is a general internist. I'm an ID doc. I have a primary care practice with HIV patients. And her strategy is, okay, I'll give you the antibiotic, but don't fill it. Just see how you do. And she comes back and she tells me that it's being filled 100% of the time. So that hasn't been working so well, but I think she's beginning the process. She's beginning the idea that the antibiotic isn't crucial, I think she's beginning to make some impact, and I'm beginning to make some impact with my outpatients as well. The CDC has great educational material. And what we're discussing in our health system is to take these posters and to put them on the wall of the exam rooms and the waiting rooms. Good news, your doctor thinks that it might be a virus and you'll get better on your own. And some of these things to kind of educate not just the patient, but also the doctor as well on the side, that antibiotics are not the go-to treatment for some of the common viral infections. And I think that's going to make an impact.
So I completely agree with communication issues that have been discussed. So I won't go further into that because that is the fundamental issue. But I will say that another area that I think spans all of the healthcare settings is really getting our prescribers to think that antibiotics are associated with side effects, and getting away from this. It's always safer to give an antibiotic, and some of the issue, particularly in the inpatient setting, is sometimes it's hard to attach the event of a side effect with your decision to prescribe an antibiotic. Sometimes they come much later after the patient is discharged. Sometimes you don't even recognize it, unfortunately. And I will say that we have worked a lot with our medicine house staff in particular, but other house staff also, hoping that we can get them as trainees and then change their practices, forever. And I do actually think it's worked because they'll often email me after they've left the institution and said, "Can you believe they're doing this at my new institution?" I'm like, "Aha, well, why don't you go fix that?" But one of the things we actually started this year, because I was personally irritated that I thought we had cases of C-Diff and people didn't even care. Like, it was almost like, well, that's just we just know that happens. Patients might get that when we give antibiotics. And I'm like, we can't behave that way. We have to think that every case of C-Diff is serious, and look at them. Are they real cases? Are they cases that aren't real, that represent colonization because of the testing methodology that we use? What's going on? So we actually started the C-Diff action team. So every day, CDAT. Oh yeah, of course, it's CDAT. And so every day, one of the infectious disease fellows who's working with me, plus minus pharmacists or me or infection preventionists, because we wanted to also get at the, some of the documentation issues about frequency of stool and the contact precautions and proper hand hygiene with soap and water. So we wanted to take this multifactorial approach, but we wanted to show up every day and say, look what's happened. You have a patient that's developed either has a positive C. difficile PCR or has C. difficile infection. And what do we need to do now to make sure that we treat this in the best possible way? What could we have done to prevent this? And what do we need to do to prevent the spread? And this is the way of engaging people. So they're thinking, like they're making the connection. Oh, I did that. And now maybe this happened. And now I should take some responsibility for this happening and think about it. So we're hopeful that has raised that feeling like we all need to care about this. It's not just the stewardship team.
So I'm going to take a slightly different angle because I agree 100% with everything everyone has said so far. But I think this is where data is really powerful. So when we talk to providers about their own prescribing practices, they don't typically think that they play a role in the problem. And it's not because they're deliberately trying to prescribe inappropriately. They're not trying to do this. They're not trying to prescribe inappropriately. They're not trying to choose the wrong drugs. But what they will say is that the surgeons, the other providers in their practice even, or the provider or the practice down the street is the problem. Or maybe it's the hospitals. Those doctors in the hospitals, they just prescribe like mad. So what is really helpful is to provide data back to individual physicians and and other healthcare providers who are doing the prescribing, and this can be done in any setting. We're talking outpatient settings. This can be done in hospitals, in nursing homes, and it really gives them insight into how they're doing. And some of the most powerful studies that have looked at how you change provider behavior have used peer comparisons. So they compare the doctor's prescribing to their peers, and they've found that that has been really powerful in changing their behavior around antibiotic prescribing. And it's just about recognizing what you're really doing and being aware of your own practices. So I think that's really been a powerful driver of appropriate antibiotic use. And I want to say thanks to Bruce for mentioning the CDC materials. One really nice poster that we put together recently is very easily downloadable, and you can just have providers put this up on their wall, and it just makes, it's a poster that describes a commitment to prescribing antibiotics appropriately. And surprisingly, if a provider just makes a commitment to prescribing appropriately, that really has a major impact on reducing antibiotic use. And displaying that publicly has been shown in doctors' offices to have a 20% reduction in inappropriate antibiotic prescribing for respiratory infections. So things like that that are very simple, almost no cost at all, can really change how antibiotics are being prescribed.
Thank you very much. So I think we're going to kick it over to the audience to see if we have any questions. I got 3 hands immediately. We'll start from the front and move our way back. How's that?
Yeah, I have a comment and a question. The question's for Laurie. But the comment is that when I got out of law school in the Neanderthal age, that you couldn't advertise on TV or anywhere else. But now you see we're on television all the time. If you breathe, you're entitled to millions of dollars. And I think that is, I know my dad he was a trial attorney, used to talk about the God-given right of trial by jury. And I once told him I didn't think that was so God-given, Dad, and I got fired. But I think that, Laurie, I think there's a real fear there that if you don't give that antibiotic and you get a bad result, any one of these guys on TV is going to turn that into 6 or 7 figures. That's number one. That's the comment. And the question is there any evidence that some of the C-Diff and some of the chickens my wife buys are passing on CD?
So I'll make a comment related to the fear piece. I don't really know what the impact of, or the possibility of transmission from, say, the deli or the uncooked meat in your freezer. You know, what might that have in terms of a risk for transmitting infections like C. difficile? There are concerns about potentially transmission of antibiotic-resistant infections in undercooked meat, potentially, but and there are some examples of that. Mostly other types of gastrointestinal or diarrheal types of infections. The issue of fear is pervasive, and undoubtedly, that's contributing to some of this problem. I think what we need to do is reset the beliefs around where the fears should really be placed. For example, there's, and again, I'm talk about a lot about the uncomplicated types of infections that don't warrant antibiotic use ever. So, for example, uncomplicated cough illness, bronchitis, leads to an antibiotic prescription in 80% of cases. In that particular instance, there is far more risk for that patient to develop an adverse event from the antibiotic than to go on to develop a pneumonia or something like that. But absolutely, everyone has heard a story, a horror story, about someone who has had a mild case of an upper respiratory infection like a sinusitis or something like that, that has gone on to cause a more serious infection. And I think that kind of situation is what still drives the overprescribing for those kinds of conditions. So without a doubt, we have to really tackle this problem and better educate providers and patients about the balance between the risks and benefits of antibiotics. The other thing we're learning, and this is work that we're about to embark on with a partner, is we're going to start to look at what the true malpractice claims are out there for related to antibiotics. Is it because patients aren't getting treatment? In some instances, for sure, sepsis, we want to make sure that patients are getting antibiotics as soon as possible. We know that lowers death, the risk of death and mortality. But for uncomplicated cases, are there situations where patients are getting antibiotics and it could be potentially harmful, and that's leading to cases of malpractice? So we're really interested in better understanding what truly is happening out there with respect to the legal system and what we're seeing in terms of cases.
Just briefly, I think Dr. Brandt had a comment about the meat question.
There's a huge literature on C-Diff in animals, both cats, dogs, ostriches, elephants, the rare animals, the common animals. But in terms of the animals that we eat on a routine basis, I think a good number to keep in mind is 30%. You can count on 30% of an infection when you go to a store and you pick up a plastic wrapped whatever you pick up. And the highest food is chorizo, the sausage. Actually, there's a German sausage, Bunch.
Is that C-Diff specific, or
Yes,
is that
C-Diff specific.
C-Diff specific. Okay.
C-Diff specific. So I actually gave a lecture to the ID division at my hospital, and they afterwards, I don't know whether they liked it or not, they gave me half a dozen chorizo.
Thank you.
We're always such a nice group.
I think I saw some questions. I'm trying to figure out how to prioritize this. The gentleman in the back there had his hand up earlier. We'll go by first come, first serve here.
I'll try and be quick, sorry. So to preface this question, is there any study specifically on antibiotic stewardship for medications used to treat C. diff? And the reason I ask is because when I had C. diff, I was given vancomycin continually, and there was no end in sight, 250 milligram tablets 4 times a day. And it wasn't until I spoke to an infectious disease doctor that they said, pulse, taper, anything? And I said, I've never heard of that before. So that kind of prompted me to, I did my fecal transplant at home because I was over it. The antibiotics weren't working for me. My question is there anyone focusing on the proper administration of antibiotics used to battle C. diff, whether it be vancomycin, Difficid, or Flagyl, or anything like that?
Jason, you want to answer?
Yeah, I'll go real quick. You know, in our hospital we do. Actually, we monitor those drugs, and actually we're working with our GI specialists because it's kind of we work together on this. And it's been really it's a fruitful collaboration, and we're even looking at the dosing of the PO vancomycin that's being recommended, and it is that kind of, we think it might be like way overkill actually, and that the dosing is ridiculous, and so we're looking at it. So I think yes, and we have to continue to improve it and work together on that.
Sarah, did you want to add some?
Yeah, I mean, it is one of the things we do as part of CDAT, and it's 2 separate things. One is, are they on what we call the non-C. diff antibiotics, which are the ones that probably cause the problem? Can we get them off? Can we switch to potentially an agent that maybe is less associated with C. diff? Because you always want to try to get them off whatever caused the C. diff. And then also, are we picking the right agent? We definitely try to get these high doses that sometimes get started down to at least, just 125. And then the other role for us, I think, is early recommendation of fecal transplant, because it surprises me, but we still have many people, because I think it's awesome. I think it's wonderful. I know. I think it's like this fundamental thing with me that I'm like, it's not antibiotics. But, we've often found that we're the first people to say, hey, why don't you think about this? This patient is now on round 2, 3. Like, it's ridiculous. The current plan isn't working. So,
Liam, did you have a question?
So you guys were talking before about the length of being on an antibiotic. As a patient, how do you know when the doctor's telling you what's too long? Because about a year ago, I was prescribed Cipro for an infection. It was
either that or a Z-Pack.
So at first the doctor wanted me to take it for, I think it was 10 or 12 days. And I was like, well, my mother died of C-Diff, let's slow down with that. So I talked him into only taking it for 5 days. And after that 5 days, guess what? My infection was gone.
Oh, great.
Yeah. So how, as a patient, do I tell a doctor, oh, that seems like a really long time, that stuff seems really strong?
So, and I'll just add that to that question. I'm sure the questions you all have been asked before by the general public or reporters is so, the doctors, the traditional educational sentiment that's been, is that you have to finish your antibiotics. Yeah.
Well, so
No, it's good. No, that was the question. So how do you reconcile with what Liam just described?
You got us going. You did.
Yeah, how do you handle what Liam just described, in addition to the whole thing out there that said half the people believe that you're supposed to finish the antibiotics to the full duration even after you feel better. And
see, nobody else is picking up the microphone here.
I'll be talking for another hour.
So for many years, we actually advocated at CDC for following the prescription as exactly as your doctor ordered it. And we still recommend that, but what we're recommending now is that when you start to feel better, and if you're considering stopping your antibiotics, call your healthcare provider. Say, I'm better. Is it reasonable for me to stop taking this antibiotic? Because I know that it could potentially be risky and not provide benefit, especially if I'm already better. So that's the kind of message we're sending at this point in time. I think the challenges and the reason why we have these football football score durations, is because the studies that have been done use those kinds of durations. And actually, many of these studies are quite old. And so ideally we'd have more studies to look more closely at duration. The other thing is everybody's different. Every single person in this room is different and will respond to treatment of an infection differently. And so it's really not easy to say that every single person should get the same amount of antibiotic. And so hopefully we'll learn more about what the optimal durations are in the future.
Communication and collaboration, and Liam, you are setting the standard because that is individualized care, and the duration of therapy, we're now thinking really differently. It's for as long as it takes, and it doesn't take as long as we used to think.
So we have time just for one more question, and if I'm sure the panelists will be happy to field any other questions we don't get to ask. I think, all the way in the back, I was patiently waiting.
This is kind of a follow-up to what you were just talking about, but I think, being in contact with so many C. diff patients who are never inpatients. The majority of C. diff patients are only treated on an outpatient basis. And it's months before they're diagnosed, and then they're made to endure months of antibiotic treatment. And then they're made to endure months of combination therapy of antibiotic treatment. And then they're made to endure months of combination of pulse taper treatment, either single antibiotics or a combination. And this is doing irreparable harm to their guts. I myself have peripheral neuropathy and ringing in my ears from years of antibiotics. But some of you will be familiar with this, some won't. Every 5 years, the 5 societies most in charge of this, APIC, SHEA, IDSA, AGA, and ACA, come out with treatment recommendations for C-Diff. And in 2015, Cliff McDonald at the CDC came out in a public phone call that many of us were on to 500 news outlets and said, fecal transplant should no longer be considered a treatment of last resort, should be offered earlier in the treatment process. The FDA language doesn't state an arbitrary second, third, fourth, fifth recurrence. It only says recurrent C. diff. Why are doctors not offering fecal transplant after 1 or 2 courses of antibiotics? New guidelines were last out in 2012. They came out this year in 2017. Johan Bakken, the past president of IDSA, came to me personally and said, I'm so sorry, we just weren't able to get there this time. The consensus wasn't there to recommend fecal transplant earlier. In the meantime, I hear from thousands and thousands and thousands of patients who are begging for fecal transplant and can't get it. And that's not really a question, it's more of a comment.
You're here.
Do you want to? Yeah, we're looking at Sarah too. Yeah.
It was interesting because we had people at Hopkins who believed in this concept from early. And so it hasn't been that hard for us to get that access. But I think that, is some of this just you have to have a gastroenterologist or an infectious disease physician who's willing to do it? Because I don't worry about the insurance issues or what the guidelines say, because I feel like I can see what's going on with someone and say, no, we don't need to do more Vanco taper. We just need to try this. And it hasn't been that big of a problem for us. But I guess I feel like maybe this is people aren't experienced with this. I think we forget that, to me, this is totally normal. It makes complete biologic sense. But some people still think, ew. And so maybe in less maybe academic areas, or I don't know. I'm curious what other people think, what the issue is, because.
We'll end with Bruce's comment there on this.
Fecal transplant is fantastic, but it is such a pain to do. It is really difficult, and I feel that the reimbursement is not there. I'm doing it, the way I do it as an infectious disease doc is to select the donor, to screen the donor, usually at the donor's own expense. The donor is either a family member of the patient or a family member of me, who is the designated donor. And the preparation and the time that goes into it is not reimbursed. It's technically very challenging. Despite that, this is a needed service. Our patients need this, and we're committing ourselves to providing this despite the disincentives of time and effort and poor reimbursement. And I really appreciate your advocacy and the Fecal Transplant Foundation to kind of push that forward. It's very difficult to be offering this experimental procedure under the current circumstances.
Thank you. And so I'd like to thank all of our panelists and all of you for participating in this session. And I believe we're going to take a break. Yeah. All right.